Hey everyone, welcome to The Explainer. Today we're tackling something absolutely critical, pediatric burn management. But we aren't just looking at the initial emergency room response. No, we are focusing on the long, complex, and incredibly demanding road to recovery. We're going to trace the steps from immediate pain management and meticulous wound care all the way through to physical rehabilitation and safely discharging the child. It's a fascinating journey, so let's get right into it.
Okay, let's dive into our clinical roadmap for today. Pain control, wound care, skin grafts, nutrition and physical rehab, and finally, abuse recognition and discharge.
Starting off with Section 1, the pain control paradigm.
I want to highlight this golden rule of burn care right out of the gate. You have to pre-medicate before a painful procedure like a dressing change or physical therapy even begins. Never, ever wait until the child is already experiencing severe pain. Think about it. Treating pain reactively means you're fighting pain that is already spiked, which is honestly both ineffective and deeply traumatic for the child. Proactive pain management is absolutely the only way to lower anxiety and ensure they can actually tolerate these life-saving treatments.
So what's in our toolkit to actually achieve that control? Well, for intense procedural sedation and analgesia, we rely on intravenous medications like morphine, fentanyl, and midazolam, and we give those just prior to starting a procedure. Then we have our topical agents, things like silver sulfadiazine and bacitracin. Those are applied directly to the cleansed wound bed to stop bacterial growth in its tracks. And later, as the skin begins to heal, we bring in antihistamines, to manage that severe, incredibly disruptive itching or pruritus that predictably happens.
But here's the thing. Meds are really only part of the equation. Healing beyond medicine is essential. Non-pharmacological methods, distraction, relaxation techniques, and developmentally appropriate therapeutic play, they aren't just nice-to-haves, they are mandatory companions to our pharmacological tools. They actively help lower a child's anxiety, boost their cooperation, and actually enhance the effectiveness of the pain medications we just talked about.
Moving right along to Section 2, wound care and debridement.
When you're at the bedside, wound care follows a very strict logical sequence. Step 1, every single time, is pre-medicating the child. Don't even touch a bandage until that's done. Once the medication takes effect, you can remove the old dressings, carefully assess the wound for red flags like odor or excessive drainage, and then cleanse the area to prepare for more intensive stuff like hydrotherapy or debridement.
And this brilliantly illustrates a stark, critical boundary that honestly gets misunderstood a lot in burn care: the difference between debridement and an eschorotomy. Debridement is exactly what it sounds like: removing non-viable, dead tissue to expose the healthy wound bed underneath so it can actually heal. An eschorotomy, on the other hand, is completely different. It's an emergency procedure used to relieve physical pressure from a restrictive burn. So imagine a full-thickness burn wrapped around a child's chest, preventing them from breathing, or around a limb cutting off blood flow. Two very different procedures for two very different immediate clinical needs.
All right, Section 3, skin grafts, both temporary and permanent.
Now, what's really interesting about this slide is how we organize these complex surgical solutions. Over on the left, we've got our temporary skin coverings. We use these to promote initial healing, protect the wound, and stop fluid loss, but they do require repeated applications. This group includes allografts from human donors, xenografts from animals like pigs, and synthetic or artificial biological products. Over on the right, we have the permanent skin coverings. This is the ultimate surgical solution, where we use the child's own undamaged tissue, like an autograft or specialized sheet, mesh, and cultured grafts, to close that wound for good.
But putting the graft on is literally only half the battle. A fresh skin graft absolutely depends on stable, close contact with the underlying wound bed so it can establish a new blood supply. That means protecting the graft site is top priority. We have to prevent movement, friction, and shearing forces by maintaining strict immobilization. And at the same time, we're vigilantly checking dressings for excessive fluids, weird odors, or fever, because an infection can easily destroy a brand new graft.
On to Section 4, nutrition and physical rehab.
Think of a healing pediatric body like an engine running at absolute maximum capacity. It needs high-octane fuel. High-protein, high-calorie nutrition is completely mandatory here. The child's body needs an incredible amount of energy to simultaneously repair massive tissue damage, fight off potential infections, and, still sustain normal pediatric growth and development. Making sure they eat enough is actively part of the medical treatment plan.
Now, as they recover, we run into a major physical challenge. I want you to think about this. Why is letting a hurting child rest in a comfortable, curled-up, flexed position actually incredibly dangerous? It goes against every instinct we have to comfort a kid in pain, right? But the answer is crucial.
Well, it's what we call the comfort trap. Avoiding movement and staying curled up causes the newly healing, highly active tissue to tighten and basically freeze in place. That leads to permanent contractures and a devastating loss of mobility. Because of this risk, strict range of motion, or ROM exercises, are absolutely mandatory to keep those joints moving, even if they are painful.
And this leads right into our long-term physical rehab tools. To fight those contractures, we have to maintain proper positioning and stay on top of continuous physical therapy and splinting. Plus, as the skin fully closes, we face the risk of hypertrophic scarring. Those thick, raised scars caused by excessive collagen. To manage that, we use specialized pressure garment therapy to apply uniform pressure, along with regular massaging and moisturizing of the healed skin.
Finally, Section 5, Abuse Recognition and Discharge. We have to shift gears here for a second, because the crucial point is this: not all burns are accidents. Identifying burns that actually result from maltreatment or abuse is a grave, life-saving responsibility. If a child's injury is intentional, sending them right back into that environment without intervention is catastrophic. So we have to be hyper-vigilant for specific red flags. Glove or stocking burn patterns on the hands or feet strongly suggest forced immersion into scalding water. We look for cigarette burns or marks that perfectly match the distinct shape of a household appliance. We also watch for suspicious delays in seeking medical care or a story from the caregiver that just doesn't match up with the physical injury or the child's actual developmental ability. The mandate here is absolute, guys. Nurses and healthcare providers must report suspected abuse immediately. You do not wait around for hard proof to report a suspicion.
Once we're confident the home environment is safe, we bring our care to a close by detailing proper discharge teaching. This is where we empower the parents. We have them demonstrate correct dressing changes and make sure they know exactly what signs of infection look like. We teach them to vigorously apply sunscreen and avoid peak sun exposure, since new grafts are super sensitive. And we focus heavily on preventing future tragedies, ensuring safe play areas, covering outlets, and critically, setting home water heaters no higher than 120 degrees Fahrenheit, which is about 48.9 degrees Celsius, to prevent accidental scalds.
We've spent this explainer looking at the immense physical challenges of burn recovery. Meticulous physical care shapes this child's body for sure, but I want to leave you with this provocative thought. How can we best support their ongoing psychosocial healing and body image as they bravely step back out into the world? Because remember, while the physical wounds might be closed, the emotional and developmental journey for a burn survivor is often just beginning. Thanks for joining me for this explainer, and keep learning.